Today I want to talk to you about pneumothorax. Pneumothorax is air in the pleural space. The pleural cavity or the pleural space is the potential space created by the visceral pleura and the parietal pleura. The pleural space or cavity has both a negative pressure and a small amount of fluid to facilitate movement of both the visceral and the parietal pleura. Perforation to either the visceral or parietal pleura will result in air getting in the pleural cavity and a subsequent pneumothorax. Pneumothorax may be classified as spontaneous, traumatic, and tension. Spontaneous pneumothoraces can either be primary or secondary. With primary spontaneous pneumothorax, there is usually the rupture of a bleb or an air cyst located on the pleura. As a result, air leaks into the pleural space, forming a pneumothorax. These patients usually do not have underlying lung disease. Primary spontaneous pneumothorax is most often seen in tall, thin men between ages 10 to 30 years. Usually, it is associated with Marfan syndrome. With secondary spontaneous pneumothorax, there are usually underlying lung diseases such as asthma, tuberculosis, cystic fibrosis, sarcoidosis, COPD, particularly emphysema, and malignancy. The next category of pneumothorax is traumatic pneumothorax. This may be caused by both penetrating and non-penetrating injuries. Penetrating chest injuries include gunshot wounds and stab wounds. Non-penetrating chest wall injuries include rib or clavicular fractures. The next type of pneumothorax is tension pneumothorax. With this, air gets into the pleural space but can't get out. Usually, there is a flap on the visceral pleura that allows air into the pleural space with each breath and subsequently traps the air. Eventually, the pressure in the pleural space becomes greater than the lung pressure, and the lung ends up collapsing. Keep in mind that tension pneumothorax can either be spontaneous or traumatic. As the pressure builds up in the pleural space on the affected side, it pushes the mediastinal structures, including the trachea, to the opposite side. This type of pneumothorax is life-threatening. Let's look at the clinical presentation of pneumothorax. Patients may present with acute dyspnea, or they may present with acute pleuritic chest pain. Almost all patients will present with tachypnea. The size of the pneumothorax will determine the clinical manifestation. A small pneumothorax may not even be noticeable on the chest radiograph. If the pneumothorax is large enough, there may be decreased chest excursion on the affected side and an enlarged hemithorax on the affected side also. There may or may not be decreased breath sounds over the affected lungs. There will be the absence of tactile or focal fremitus. Also, there will be hyperresonance on percussion. According to the British Thoracic Society, a pneumothorax is small if the distance from the chest wall to the visceral line is less than 2 centimeters, and it is large if the distance is greater than 2. A distance of 2 centimeters or greater roughly correlates with a 50% pneumothorax. In the United States, on the other hand, a 3 centimeter distance from the pleural line to the chest wall is used to determine small versus large pneumothoraces. Let's talk about the treatment. Pneumothoraces or a pneumothorax may be treated with observation, aspiration, and tube or catheter thoracostomy. So let's look at each. Where observation is concerned, supplemental oxygen and observation is generally the strategy used in clinically stable patients with a first episode of primary spontaneous pneumothorax that is small and without severe symptoms. Next, aspiration. Aspiration is generally performed in clinically stable patients with a large primary spontaneous pneumothorax in facilities with expertise. Catheter rather than needle aspiration using equipment available in most commercial thoracentesis kit, since needle aspiration alone may increase the risk of perforating the visceral pleural membrane and perpetuate the pneumothorax. And then lastly, tube or catheter thoracostomy. Chest tube thoracostomy refers to the insertion of a standard chest tube, while catheter thoracostomy refers to the insertion of a catheter, example a pigtail catheter, in the pleural space. Choosing among them is often the discretion of the clinician and available expertise. Here are some pearls I want you to take with you before we close off this session. Tension pneumothorax is a clinical diagnosis, and the chest x-ray is not needed for the diagnosis. It is treated with a large bore needle aspiration. The needle should be placed in the second intercostal space mid-clavicular line. Then small pneumothoraces may be missed on chest radiograph. Also, if the pleural line is less than 3 centimeters from the chest wall, it's a small pneumothorax, and if it's greater than 3 centimeters, it is large. A large pneumothorax needs a chest tube, while small ones may be observed with supplemental oxygen. Breath sounds may or may not be present based on the size of the pneumothorax. And hyperresonance on percussion is based on the size of the pneumothorax. The classic presentation is pleuritic chest pain and shortness of breath. And the imaging modalities that are now used are ultrasound for bedside evaluation for unstable patients, chest x-ray as the initial test for pneumothorax, with the exception of tension pneumothorax, which is clinically diagnosed. And thirdly, CAT scan of the chest is the imaging modality of choice to make the diagnosis. Okay, well, thanks for watching. And again, please don't forget to like, share, and subscribe. I wish you well. Good night.